Hello students. So now let us see the recall questions of ENT of INI-CET November 2022. Now in ENT, in the session 1, this time we had 2 sessions. So in the session 1, in ENT, around 4 questions could be recalled, and in the session 2, around 8 questions of ENT could be recalled. So let us quickly see what those questions were. And so we first start with the questions of the session 1. And in the session 1, let us quickly have a look at the distribution of the topics. From the year, we had 2 questions, out of which one was from audiology and evaluation, which is a very important topic for INI-CET, a repeated topic which is asked. And we had a question from Tympanoplasty. From the nose, we had 2 questions, and both of them were from anatomy itself. So let us see what these questions were. So we start with the first question. So the first question reads, which of the following tests will you combine if autocaustic emission is absent in a patient? Okay, so here we have a patient for whom we have done autocaustic emission, and that has turned out to be absent. So how do we go about? What is the next step? That is what is being asked here. Let us look at the choices. Pure tone audiometry, tympanometry, free field audiometry, and speech audiometry. Okay, so we have done the concept behind this question innumerable number of times, but let me quickly recap before we come to the answer of this question. And before I tell the answer of this question, you are going to, as we recap, you are going to answer a few questions for me. And this question I'm going to take up a little bit in detail, because this topic of autocaustic emission is a very, very important topic, a repeated topic. So yes, be very attentive while we do the recap and come to the conclusion of the answer of this question. So now the first thing I want you to tell me is, what exactly do you understand by autocaustic emission? Yes, autocaustic emission is acoustic emission, which means it is a sound that is produced from the ear. Yes, exactly from where? From the outer hair cells. Right. Now, how is it produced? What is the procedure of the autocaustic emission to be produced? Yes, so whenever there is a sound, what we do here is we give a sound in the external auditory canal through a probe in the external auditory canal, and we give a sound. So that is why this autocaustic emission that we test is what is known as evoked autoacoustic emission. Again, this has been a question of your exam. Which one do we test, spontaneous or evoked? We test this evoked one. So we give the sound in the external auditory canal. This sound travels to the middle ear, and then it goes to the inner ear. And in the inner ear, it leads to the activity of the outer hair cells. Yes. Now, this activity of the outer hair cells in turn produces a sound. This sound travels back from the middle ear to the external auditory canal, and this can be picked up by the probe in the external auditory canal, which means that if we have given a sound while testing the autocaustic emission and we can record back a sound, which means that the outer hair cells of this patient is normal, which is an indication that cochlea of this patient, the inner ear, is normal, right? So, okay. So now coming to the most important thing is, we know everything about this test, how this test is done, what exactly it indicates. Now, when will you like to do this test in any patient? Now, in this question, it is just given that we have done autocaustic emission in a patient. The age of the patient is not mentioned here, whether it is a child or whether it is an adult. So let us see when we do this test in an adult and when we do this test in a child. Now, in an adult, let us suppose that here is a patient who has come to us with hearing loss. Yes. So when the patient tells that I feel I'm not hearing properly in my ears, is autocaustic emission the first test that you prescribe to the patient? Tell me. No. Yes, what do you do first? If suppose this patient is sitting in front of you, is telling that I feel I'm hearing less, what do? Yes, the first thing that you do is you examine his ears. You see that up till tympanic membrane, everything is good. So now you want to see whether there is actually hearing loss or not. The first test that you do is, yes, the tuning fork test. So suppose the tuning fork test show that there is a sensorineural hearing loss. Now, what is the next step? Yes, tell me. Yes, you will now go for a pure tone audiometry. The pure tone audiometry will confirm that yes, there is a sensorineural hearing loss. It will also tell you how much is the hearing loss. So you first did a tuning fork test. And then you did a pure tone audiometry. Pure tone audiometry showed that there is a sensorineural hearing loss. Okay, it showed that there's a sensorineural hearing loss. Now you want to find out whether this hearing loss is sensory or neural, whether it is cochlear or retrocochlear. So now you go for the test which will differentiate whether it is a cochlear or a retrocochlear hearing loss. So one of them is autoacoustic emission, right? So you go for autoacoustic emission in adults only when the pure tone audiometry has shown that there is a sensorineural hearing loss and we want to differentiate. Is that very clear? Now, if the autoacoustic emission here is present, then we know that the cochlea is normal. So where is the defect? Retrocochlear, right? So accordingly, you can come to the diagnosis that yes, this is the defect, and you can look up to what is the defect in the retrocochlear or in the cochlear area according to the result of the autoacoustic emission. Now, coming to newborn or in children, when you do the autoacoustic emission in children, yes, we know that this is now a part of this is in fact a test that we do for universal neonatal hearing test screening for hearing in neonates, and that has been a repeated question of your exam. Yes, so which means that a child is born, whenever a child is born and we want to know whether the child is hearing or not, whether the cochlea is good or not, we cannot go for a pure tone audiometry. That is a subjective test in an infant newborn. We cannot go for this test. So we directly go for autoacoustic emission there. Yes, we do not go for any pure tone audiometry there. Now, suppose if it is a child who is maybe 6 months, 1 year, 2 years, 4 years, 3 years, and the parents have got the child to you and they have not got any autoacoustic emission done any time earlier, and now they are telling you that we feel that our child does not hear. Yes, so now what will you do? Will you now subject the patient, a child of 4 years, 3 years, 2 years for pure tone audiometry, or would you directly recommend an autoacoustic emission? Yes, we know that for pure tone audiometry, which is a subjective test, we entirely have to depend upon what the patient tells us. Patient will tell that I'm hearing, we will mark that yes, patient has started hearing at this loudness. So this we cannot trust if it is such a small child, less than 7 years of age. We usually do not rely on the child's response. So less than 7 years of age, we do not get a pure tone audiometry done. So before that, nowadays we directly go for an autoacoustic emission test or a BERA done. Depending upon the result of the autoacoustic emission, we can get a BERA done also, right? That will tell us exact threshold. The BERA will tell you exact threshold of hearing of the patient. Now, in earlier times, when this autoacoustic emission and BERA were not very frequently available, when they were very, very expensive, so some preliminary tests used to be done. Suppose the patient has come to the OPD with a complaint, the parents have got the child that the child is not hearing. Maybe they are not sure that the child is hearing or not. So some preliminary tests used to be done by giving a loud sound and seeing the response of the child in response to the loud sound. So we used to observe the behavior of the child in response to the loud sound, and we used to get a working knowledge of whether the child is hearing or not. That was what was known as, that in fact is what is known as behavioral observation audiometry, right? Now, in behavior observation audiometry, we have to know what the age of the child is, and a child of such age responds to how a child of such age responds to sounds. For example, if it is a very small neonate, 1 month, 2 months, 4 months, yes, up till 5 months, the children will get startled with sound. So you can just in the OPD ask some person to give a very loud sound, a clap or a loud sound, and you can see if the child is getting startled. If the child is sleeping, then maybe he will just wake up. That is what is known as the arousal reflex. Or maybe if there is a loud sound, the child will quickly blink his eyes. So these indications in response, these behavioral changes in response to the sound gave us a slight idea that yes, the child is hearing or the child is not responding at all to sound. Now, if it is a child who is 6 months, from 6 months onwards, we know that after 6 months, the child is able to localize the sound, which means that he will turn the head towards the source of the sound. So in this group of children, how we came to an idea whether the child is hearing or not was by placing this child in a room where there were loudspeakers attached on both the sides, and sound was given from one loudspeaker at a time, and it was noticed whether in response to the sound, the child turns the head whenever there is a sound. So suppose a sound is given, you see that the child turns the head towards that side, towards the loudspeaker which is producing the sound. It means that yes, the child is hearing. Yes. So this test which was done in open area, this is what is known as free field audiometry. Yes. And sometimes also what used to be done, because children get bored very quickly, a toy used to be placed at the top of the speaker, so that whenever the child turns the head towards the sound, he will see the toy and the toy will start playing. The coordinator used to start playing the toy. So the child will be interested in doing this. Now, when the child is more than 2.5 years of age, up till 5 years, then we know that children of this age group will respond to your commands. So in these group, if we wanted to get a working knowledge of if the child is hearing or not, what was done was play audiometry. What is play audiometry is that the child is given a game that, okay, these are balls and you have to put it in this basket whenever you hear a loud sound. And a reward was given whenever the child will do it as he hears the sound. So this was play audiometry. Now these are very basic tests. Now this will just give you a working knowledge of whether the child is hearing or not. Now if the child is not responding, we will not have any idea whether it is a conductive hearing loss, whether it's a sensory, or whether it's a neural hearing loss. So nowadays what we do is, if there is any suspicion of hearing loss, we directly go for acoustic emission, and if there is any defect in that, or according to the result of that, we can go for BERA to find out threshold also, or to confirm whether it is what hearing loss, right? So this was what is behavior observation audiometry. This is nowadays, I should say, not used for diagnosis of hearing loss. We do not use it. Okay, so in newborn, if we are suspecting any hearing loss, we directly go for a autoacoustic emission, and then according to that, we can result, or we can also go for BERA, right? So now we know when we go for this test. Okay, now coming to, we have done this test either in an adult or in a child, and we have got the result as present. The autoacoustic emission is present. So this is a very important part. Listen to this very carefully. So if the autoacoustic emission is present, what do we say? We say it is passed. This was another question that was asked in your exam. So if the autoacoustic emission is present, what does it indicate? Tell me what it indicates. Yes, it indicates that the outer hair cell is normal, which means that the cochlea is normal, right? It means that the cochlea is normal. Okay, now I will ask you another thing. If the autoacoustic emission is present, does it only indicate that the cochlea is normal, or does it also indicate that the middle ear and the external ear is also normal? Yes, I just told you that the sound goes from the external ear to the middle ear and then to the inner ear. And from the inner ear, from the outer hair cells, again back to the middle ear and then to the external ear where it is recorded. Which means that if I am getting the autoacoustic emission recordable in the external auditory canal, it means not only that the inner ear is normal, it is also indication that sound was able to reach the inner ear through the middle ear, which means that the middle ear of this patient is also normal. Had the middle ear not been normal, and if the sound was not able to reach the inner ear, in spite of the inner ear being normal, we wouldn't have been able to get any response. So in the autoacoustic emission, if it is present, it indicates not only that the cochlea is normal, it also indicates that the middle ear is normal, the external ear is also normal. Any hearing loss more than 35 decibel, any conductive hearing loss more than 35 decibel will not lead to the sound travel into the inner ear or back from the inner ear into the external auditory canal, right? Now, if so, it is the conclusion is that the middle ear is also normal and the inner ear or the cochlea is also normal. That is the conclusion we get when the result is passed. Now, if the autoacoustic emission is absent, then we do not say that it is fail or negative. What we say, as was given in this question, autoacoustic emission is absent. Yes. So either absent, or in the report is written refer. So whenever we see a refer, we get the clue that the autoacoustic emission was absent. Yes. So it means that refer for what? Yes. So now we are coming to very important thing, refer for what? Tell me refer for what. So if the autocaustic emission is not present, if it is absent, the first thing that we have to be sure about before labeling that in this child the cochlea is not functional. That's a very big thing to label, that the cochlea is not functional, inner ear is not functional in this child, in this patient, be it a child or be it an adult. Yes, before that you need to be very sure that the sound has reached the inner ear. Yes, so what we do is whenever the autocaustic emission is absent, the first thing is we examine the external ear and we rule out that the external ear is good. By chance, if there is any wax or anything in the external ear, clean that, get a repeat autocaustic emission done. And if the autocaustic emission is still negative, then rule out whether the middle ear is normal or not. That is by tympanometry. So tympanometry, if it comes out to be normal, means middle ear is normal. External ear, we have seen that yes, it is normal. Now, if still the autocaustic emission is absent, it means that the external ear is good, the middle ear is good, means actual the defect is in the inner ear. Right? So the first thing we refer for or we get done if the autocaustic emission is absent is to see whether the middle ear is normal or not. That is tympanometry. Tympanometry, right? Now, the second thing that we want to see when the autocaustic emission is negative and we have seen that the middle ear is normal. So now we know that the cochlea of this patient is not functional. So now we want to see, is the nerve also not functional or is the nerve good? By chance, we want to go for replacement of the organ of Corti by cochlear implant. We know that the nerve should be functional. Yes, so we want to now see that whether the nerve is functional or not. So for nerve functional or not, we can go for Bera, or we can, if it is an adult, then we can go for any other test also which can tell you about the retrocochlear pathway, about the neural pathway, right? So any test about the neural pathway or the retrocochlear pathway. Is that clear? Are you with me? Okay, so now let us come to the question. So here, which of the following tests will you combine if autocaustic emission is absent? So autocaustic emission is absent in the patient. The age of the patient has not been mentioned, whether it is a child or an adult. So which test will you combine? Yes, we know that tympanometry we are going to combine. Definitely, we are sure about that. What about pure tone audiometry? Will you like to go for pure tone audiometry if the autocaustic emission is absent in a patient? After that, will you like to go for pure tone audiometry? Yes, I just told you the sequence in great detail. What is the sequence? Pure tone audiometry is always done before we do it. Is done as a preliminary test, and the autocaustic emission is a more specialized test. Now, suppose you are not remembering this and you get a pure tone audiometry done again. What will it tell you if the autocaustic emission in any patient is absent? Yes, suppose it is absent and you get a pure tone audiometry done. If the autocaustic emission is absent, we already know that the patient has a sensory hearing loss. Yes, so the pure tone audiometry will maximum tell you that there is a sensory neural hearing loss. It will not tell you whether it is sensory, whether it is neural. The autocaustic emission has told you more specialized result that it is sensory. Now you want to check whether the neural pathway is good or that is also gone. That a pure tone audiometry will not tell you. So no, pure tone audiometry, no. Free field audiometry. What do you think? Free field audiometry is just a very, very basic test that will just tell you whether the child is hearing or not. And in any child or in any patient where the autocaustic emission is absent already, we know that there is some hearing loss. Yes, there will be the cochlea which is defective if the tympanometry is normal. Yes, so definitely this child will not be able to hear. What will you gain by doing a free field audiometry? You give the sound, the child will not respond because his cochlea is not functional. What more will you get after doing autocaustic emission if you're doing a free field audiometry? So this pure tone audiometry, or if at all free field audiometry also, if you get done, these are preliminary tests. The autocaustic emission has to be done after these. Yes, so no, not free field audiometry also. So speech audiometry, can speech audiometry tell you about the retrocochlear pathway? Yes or no? Yes, we know that speech audiometry it has two parts. What is speech audiometry is that in pure tone audiometry, we give pure tones to the ear with the help of headphones and we see whether the patient is responding or not. Speech audiometry is we are giving the sound not in the form of tones but in the form of our speech, words. And we are recording how many words the patient is able to identify or not. So speech audiometry has two parts: speech threshold, that will give you a threshold of hearing of the patient, and the other is discrimination score. This is the ability of the ear of the patient to discriminate between different words, pin, thin, rin, sin, whether he's able to discriminate or not. Yes, that is what is discrimination score, and discrimination score is a function of the nerve. And again, this question has been asked repeatedly in your exams, the rollover phenomena. Yes, what is the rollover phenomena? Rollover phenomena is when we plot the discrimination score against the amplification of sound. The result tells us whether it is a cochlear hearing loss, whether it's a conductive hearing loss, whether it is a retrocochlear hearing loss. So what we do here is we give the patient words, and we go on increasing the loudness. We go on amplifying the loudness of the words, and we see how many percentage of words the patient is identifying as we go on increasing the loudness of the sound. So what happens in cochlear hearing loss is, as we increase the loudness, suppose I am speaking very softly, then I speak a little more louder, then a little more louder. When are you going to hear better? Yes, the louder the sound, you will hear better. So in cochlear hearing loss, what happens is, as we increase the loudness of sound, the patient, he is able to discriminate more number of words clearly. Yes, but after some time, what happens is, the level of words that he is able to identify does not increase any further, and it reaches a plateau. This indicates a cochlear. It never reaches 100% mark that all the words that we are speaking, the patient is never able to identify all the words. But yes, as we increase the loudness of sound, the number of words that he identifies correctly, discriminates correctly, increases, and then it becomes plateau before he is not able to identify all the words correctly. Yes. Whereas in retrocochlear hearing loss, what happens is that as we increase the loudness of sound, the patient is able to identify more number of words, discriminate more number of words correctly. Yes, and it reaches a peak which is much below the normal. But after some time, once it has reached the peak, now if you increase the loudness of sound further, now the number of words that the patient was able to discriminate earlier goes down. It goes down. Why? Because his nerves had got fatigued. So whatever sound they were appreciating earlier, now they are not appreciating that also. So this is what is rollover phenomena, and this plot we make by discrimination score, and rollover phenomena is indication of nerve fatigue. This is indication of neural hearing loss, neural deafness. So now here the best answer would have been Bera if Bera was given in the choice. But yes, that is what the examiners do. Every time they will not give you the same choices. So what they did here in this question is, they did not write infant, where if it was an infant or if it was a child, then we couldn't have done this subjective test of speech audiometry. We could have done only Bera. So they did not give the age of the child, and instead of Bera, they just replace that with another test which tells you about the neural hearing loss. But if your concept is clear that if autoacoustic emission is absent, the next thing that we are going to do, we want to find out is if the middle ear is normal or not, and second, if the nerve is normal or not, then you could answer this question. So always beware. The concept will remain the same. Just see where the changes have been made in what thing. Accordingly, you will be able to answer the question. So let us see the choices. Yes, so we have tympanometry and speech audiometry as the answer. So B and D. Do we have that? Yes, C. So the answer here is C. I hope you understood that. And coming to the next question, match the following: Woolston tympanoplasty and procedure. Okay, so here we have the various tympanoplasties given in the first table, type 2, 3, 4 and 5. And in the procedures has been mentioned fenestration, graft over incus, cava minor and columella. Yes, so I have told you in the lectures also that tympanoplasty is very simple to remember. The three tympanoplasties, 1, 2, 3 is on the first ossicle, second ossicle, third ossicle, right? So yes, what is type 1 tympanoplasty? Type 1 is when we place the temporalis fascia graft over the first ossicle, that is the malleus. That is what is type 1 tympanoplasty, and that is similar to myringoplasty. Now, type 2 is when we place it over the second ossicle. What's the second ossicle? Second ossicle is in the incus. So, when we place the temporalis fascia graft over the incus, that is type 2. That is known as myringoinchidopexy. Now, type 3 is when we place it over the third ossicle. What's the third ossicle? The stapes. So, when we place it over the stapes, that is type 3. And this is what is known as myringostapediopexy. This is also known as columella tympanoplasty. And why it is known as columella? Because this gets the name from the middle ear ossicles in birds. In birds, there is only one ossicle in the middle ear. That ossicle is known as columella. So when in the humans there is only one ossicle left in the middle ear, we call it as columella tympanoplasty. So which one is that? That is type 3 tympanoplasty. Now what will be type 4? Is type 4 when we place it over the footplate of stapes. We remove the ossicle one by one, malleus, then incus, then stapes. Now what is the 4? Is it over the footplate of stapes? No. If we place it anywhere over the stapes, either over the head of the stapes or over the footplate, that is what is type 3. Is that clear? So when we place it directly over the head of the stapes, that is also type 3 or columella. When we place some prosthesis over the head of the stapes and over that we put the graft, that is also type 3. If we put a big prosthesis over the footplate of stapes and then we put the graft, that is also type 3. So all these are type 3, all these are columella. And this one, when we put prosthesis over the head of the stapes, this is what is known as POP. And this was a question last year of INI-CET. The image was given of POP and of TORP. So this is total ossicular replacement when we put the prosthesis directly over the stapes footplate. So whether we put the graft over the head of the stapes or over the PORP or over the TORP, this is what is type 3 or columella tympanoplasty. Then what is type 4? Type 4 is, now here we have the middle ear, here we have the posterior part, the anterior part. In the posterior part, we know we have the oval window, we have the round window. So now what we do is that we place the graft in between the oval and the round window. So this oval window is directly in communication with the external auditory canal, and this round window is covered by the temporalis fascia graft. So what we have done is we have made a small middle ear cavity. This is what is known as cavum minor, as you are seeing here, and the oval window is directly exposed to the external auditory canal. So what we are doing here is we are maintaining the phase difference so that sound does not reach both the windows at the same time. That will lead to cancelling of the sound. So what we are doing in type 4 is we are maintaining the phase difference. This is what is cavum. What we are doing here is we are making a small middle ear cavity or cavum minor. And what is type 5? Type 5 is done when the footplate of stapes is fixed. When the footplate is fixed, then what surgeons thought is that now the footplate is fixed. They saw another bulge above the footplate. What is this bulge? Yes, this is the bulge of the lateral semicircular canal. So they made an opening there, a fenestra there. This was known as fenestration operation. This was done for which condition if the footplate is fixed? Yes, autosclerosis. So this was done for autosclerosis. It is no more done now. If you're making a fenestra opening on the lateral semicircular canal, that will lead to pressure changes going inside the inner ear and vertigo. So that leads to positive fistula test. It is no more done. So now let us see this question. So what is type 2? Type 2 is over the second ossicle, over the incus. So what is that? Yes. So this is, A is 2. What is B? B is type 3. 3 is columella, that is 4. And C is type 4. Type 4 is either it would have been given phase differences maintained, yes, or here it has been given cavum minor, so that is 3. And D is type 5. Type 5 is fenestration, that is 1. Yes. So now coming to the next question, and this is which test is not used in testing olfaction? Smell diskettes, University of Pennsylvania smell identification test, cross-cultural smell identification test, and Arnold sticks. Yes, so testing olfaction has gained significance after COVID. So how do we test olfaction? Out of all these, the most universally accepted and the most widely done is University of Pennsylvania smell identification test. What is asked in this question is not used. Yes, so this is used. We already know that. Now, what is cross-cultural smell identification test? What is University of Pennsylvania smell identification test? In this, the odorant is encapsulated in this area, which needs to be scratched by the patient with the help of a pencil. The patient needs to smell it, and there are 4 choices given here. He needs to mark the most appropriate that he feels is the smell. So this contains 40 scratch and sniff questions. Now, if of this 40, if we take around 12, and which are very common in most of the cultures, that is what is known as cross-cultural smell identification test. That is a part of University of Pennsylvania smell identification test. And this in short form is also known as UP-CIT. SIT is smell identification test. And this is also known as BCIT. BCIT is brief smell identification test. Only 12 out of the 40 are selected here, which are the most common smell which anybody in different cultures also will be able to identify. And what is smell diskettes? The name itself tells they are small smell discs. Yes, they are a group of 8 that are provided in one pack. And again, the patient is supposed to smell and identify among the 4 options, among the 4 multiple choice questions, which is matching most closely to the smell that he feels he is smelling. So all these tests, even if you do not know the names of these tests, yes, the smell diskettes, the smell identification test, again the smell identification test tells you that yes, this is something for testing smell. The Arnold sticks is, yes, the odd man out. This is not used for identifying or for testing olfaction. Now, do we use any sticks also in testing olfaction? Now, for testing olfaction, I just showed you that they are the odorants are provided in the form of microencapsulated disc or in the form of scratch and sniff. They can also be provided in the form of pencils or pens. They are known as stiffing sticks. So yes, this can be used for testing smell, but not Arnold sticks. There is nothing like Arnold sticks for testing olfaction. Coming to the next question, which of the following tests cannot be used for mucociliary clearance? So here it is asked, cannot be used for mucociliary clearance. Yes, so I have taken up this question, though the mucociliary clearance, yes, it is present not only in the nose, but in the lower airways also. It is a function of the whole of the airways, the upper airways as well as the lower airways. And the testing of mucociliary clearance is of importance when the absence or impaired mucociliary clearance leads to repeated infections, mainly of the lungs. Yes. So in which condition do we usually test the mucociliary clearance? In primary ciliary dyskinesia. Can you tell me any example of this? Yes, Catagna's syndrome, or in cystic fibrosis, where we know that the clearance is impaired. So that is where we usually apply this test. But this test is very commonly applied in the nose. Applied in the nose, by that I mean is that the test is done by placing things in the nose, because to test in the lungs is a little difficult. To place things in the lungs and to note the mucociliary clearance there is a little difficult. So how do we test the mucociliary clearance? Yes, what do you think should be the answer here? We have 4 choices: saccharine test, electron microscopy, scintigraphy, and charcoal powder method. Suppose you have not heard of this, what would you most likely mark? So let us see what these tests are. What is saccharine test? Yes, saccharine is placed on the inferior turbinate, and the time is noted between placement of the saccharine on the inferior turbinate and the patient reporting a sweet taste. So that indicates that the saccharine from the nose has got cleared into the oropharynx, and this time is, if it is less than 30 minutes, anywhere between 10 minutes to 30 minutes, that is considered as normal. So that is what is saccharine test. Now, saccharine test was mainly totally a subjective test. Only when the patient says that I am now perceiving a sweet taste in my mouth, we know that yes, this is the time, this is the mucociliary clearance time, right? Now, this can be made objective also. So there are few articles which mention that, and that along with the saccharin can be stained with the help of methylene blue or indigo or charcoal. In fact, this charcoal thing has been a very recent paper in 2022, which is not yet in books. But yes, this can be put, and this will help even the examiner to identify the color coming into the oropharynx, which will, or you can examine endoscopically where the color is to see exactly where it has reached in how much time. So yes, saccharine test, yes. Scintigraphy, what is charcoal powder method also? Yes, charcoal powder can be mixed either in the saccharine, or it can be done just separately. We know it is very readily available. We know it is black in color. So, but this will become a total objective test. You will have to put the charcoal on the inferior tabinate and keep visualizing the oropharynx after a little time to see the black color appearing in the oropharynx. Now, the same thing can also be done by placing radio-labeled isotopes in the form of aerosols. So the patient is made to inhale these aerosols, and they are followed by gamma camera, by scintigraphy, to see whether how much is the clearance, where it has reached, whether it has reached the oropharynx or it has reached the lungs also. So accordingly, the clearance time, the mucociliary clearance time is calculated. So yes, scintigraphy can also be done. What can electron microscopy do? Electron microscopy, yes, can observe the cilia. It can tell the ultrastructure of the cilia, whether it is normal or not. But it has been found that around 30% of the cilia, even if they appear normal, might not be functional. And also at the same time, now if the cilia is functional, but if there is any obstruction anywhere, in spite of all the cilia being functional, the clearance time will be delayed because of edema, because of obstruction. So electron microscopy will just tell you that the ultrastructure of the cilia is normal. But still, in spite of this being normal, the clearance time could be delayed. So it will not be an indication of the mucociliary clearance. So that is the answer. This will not be used for mucociliary clearance. The answer is B here. So these were the questions of the session 1. Now coming to the session 2, let us quickly have a look at the distribution of the questions of session 2. Yes, session 2 were more simpler as compared to the session 1 in ENT at least. So here in ear we have 3 questions. One is from the audiology and evaluation from the tuning fork test. Other is from the autocaustic emission. We had 1 question from autocaustic emission in session 1 also. The other was from the sinusitis media. From the nose, we had 3 questions. And again, we can see that these are the topics which we have always said that these are the important topics. So you have to do it, though. Tuning fork, autocaustic emission are a must questions always in INI-CET. From the nose, we had 3 questions again. 1 from anatomy, 1 from sinusitis, and 1 from granulomatous conditions of nose. From the pharynx, we had 1 question that was from nerve supply of the tongue. That is again favorite of the INI-CET. And from the larynx, again a favorite of INI-CET, the nerve supply of the larynx. So let us see what these questions were. Coming to the first question, a patient complains of decreased hearing in the left ear. His audiogram is given below. What would have been the tuning fork test in this patient? Yes, and this was a question that I had made as a practice question by the author for the book ENT for entrance exams. Yes, and that was, I think, it has been there in that book for 4-5 years now. And to see this exact same question in INI-CET, I was so glad. So now but yes, this is not a difficult question. Anybody whose concept is clear in the audiogram as well as the tuning fork test could have answered this. So what are we seeing in the audiogram? We are seeing that, yes, let us see one by one. This is the right red color, and the round is also telling you this is the right ear. Up till 25 decibel is normal. So these are the steps that I'm following, that I have told you also you should be following. Always see one ear first whenever the audiogram is given. Second, when you are seeing that particular ear, always see first what is normal. So up till 25 decibel we consider as normal. So here we can see that the right ear is normal, right? So in this patient, the right ear is normal. The right ear is normal. Let us see about the left ear. In the left ear, what we are seeing is that, yes, there is no AB gap. The left ear has a low frequency, no AB gap, so sensorineural hearing loss. So in the left ear, there is a low frequency sensorineural hearing loss, right? Okay, so now what is asked is the tuning fork test, Rennie's and Weber's. So as I've always told you, whenever we are going to answer a question on tuning fork, how should we write down? Yes, we will write right ear, we will write left ear, and we will write Rennie's and Weber's in the center, right? So in the right ear, we have made the diagnosis. Right ear is normal and left ear has sensorineural hearing loss. So what will be Rene's? If it is normal, Rene's will be positive, and if it is sensorineural hearing loss, Rene's will be again positive. Now, what will be Weber's if there is a sensorineural hearing loss of the left side? Yes, we know Weber's is always towards the better side in sensorineural hearing loss. What was the mnemonic? SOCS. SOCS. In sensorineural hearing loss, it is towards the opposite side. In conductive hearing loss, it is towards the same side. So this is Weber's will be towards the right side. So now let us see. Now here we can see left ear Rene's positive, Weber's to the right. Left ear Rene's positive, Weber's to the right. Yes, we have got the answer in the first choice itself. And anyway, we can see in B choice and in D choice it is negative. So this is automatically ruled out. You have to just choose between two. And what is the deciding factor here is the Weber's, right? So the answer is very simple here. The answer is A. Now coming to the next question, arrange in sequence the pathway of production of autoacoustic emission. So yes, we already know what is the pathway of production. We know that we pass a probe in the external auditory canal. Yes, and through this probe a sound is given, and this sound goes first to the external auditory canal, then to the tympanic membrane, then to the middle ear, and then through the oval window it goes into the inner ear. Yes, in the inner ear, where does it reach first? Yes, oval, V for oval, V for vestibule. So into the vestibule, from there to the scala vestibuli, right? And then through the helicotrema to the scala tympani. And then the round window moves out. And this produces shearing action, movement of the basilar membrane. And this activity of the basilar membrane, movement of the basilar membrane makes the outer hair cells move. And the activity of the outer hair cells produces a sound which is now transferred back from the middle ear to the external auditory canal, and it is recorded back by the probe in the external auditory canal. So now let us see what the choices here are. Yes, so we know the pathway. It is outer hair cells, basilar membrane, ossicles, oval window, tympanic membrane, perilymph. Okay, so now let us arrange. Yes, first will be the tympanic membrane. Yes, so 5. Next, from the tympanic membrane, what do we have? Middle ear, we have ossicles. Okay, so 3. And then from the ossicles, yes, the oval window, that is 4. And then from the oval window, outer hair cells, basilar membrane, perilymph. Yes, so from perilymph, yes, it will go into the inner ear, where in the perilymph. That will lead to movement of the basilar membrane. So then will come the 2 basilar membrane and then the outer hair cells. So let us see if we have this combination anywhere in the choice. 5, 3, 4. 5, 3, 4, all this. 6 to 1. 6 to 1. Yes. So this is the answer. The answer here is B. So coming to the next question, a 6-year-old boy presented with recurrent upper respiratory tract infection, poor growth, high-arched palate and impaired hearing. His tympanogram is given below. What would be the most appropriate management for him? So let us quickly see what the tympanogram is showing. Is the tympanogram is a B type. B type indicates, yes, fluid in the middle ear, very good, sinusitis media. So here it is a 6-year-old boy, and as I told you, this is a repeated question in INI-CET or in NEET. A child has been given nasal obstruction or impaired breathing or decreased hearing or mouth breathing, all these. Yes, we have to think about adenoid hypertrophy, or we have to think about, if only ear features are given, we have to think about sinusitis media in a patient of adenoid hypertrophy. So 6-year-old boy presented with recurrent upper respiratory tract infection, high arched palate means mouth breathing, impaired hearing, that is diagnostic here also, that there is sinusitis media. Yes, all this indicates that this is a patient of hypertrophied adenoid hypertrophy along with serous otitis media. So what would be the most appropriate management? Yes, we have to treat the cause, that is the hypertrophied adenoid. That we will do by adenoidectomy. And the serous otitis media in the ear will be treated by myringotomy and grommet. Let us see what the choices are. Myringotomy, grommet, myringotomy and grommet, adenoidectomy and grommet. So what do you think will be the best answer? In fact, this has been a direct repeat, and I think, yes, the students were telling me that the same, by chance I have just told while doing the serous otitis media myringotomy topic also, that this has been a previous question that has been asked, and ditto same question was asked this time in INI-CET. So yes, adenoidectomy and grommet. Why not just myringotomy and grommet? If you're putting a grommet, it is but obvious that you cannot put a grommet without doing a myringotomy. So if it is said that you have put a grommet, myringotomy is understood that you have done. Yes, so the most appropriate answer here is, adenoidectomy and grommet. So coming to the next question, the mark structure opens in which area? Which is the mark structure? Here the sphenoid sinus has been marked. The sphenoid sinus, this is the marked here. So it opens in which area? Yes, we all know it opens where? It opens above the superior meatus in this area, which is the sphenoethmoidal recess. So coming to the next question, 35-year-old female presented with a complaint of nasal obstruction and postnasal drip. There is a past history of FES following failed conservative treatment 5 years back. Post-surgical notes says uncinectomy done and maxillary ostia dilated. DNA this time shows patent ostia with mucosal edema in the maxillary sinus lining. Next best step of management. Okay, so here we have a patient who has come to us with a complaint of nasal obstruction and postnasal drip, right? There is only nasal obstruction and postnasal drip. And right now, when we are doing the endoscopy, what we have found is that everything is patent, good. Only there is mucosal edema in the maxillary sinus lining. And this patient has given a history that 5 years back, the patient has got operated, a FES has been done. So right now, when the patient has come to us, and this is the finding that we are seeing in the nose, our main aim of management will be focused on resolving the edema of the mucosal lining. Because we know that if the edema progresses, this is the patient who has already undergone FES earlier. So maybe this was a patient of polyp, nothing has been mentioned. This was a patient of allergy where there is some starting of recurrence. There is now mucosal edema, and the patient now has started having nasal obstruction and postnasal drip. So we have done endoscopy and there is mucosal edema that can progress again to more edema, blocking the osteometal complex, and that can lead to again chronic sinusitis, and that can lead to polyp formation also. So right now we have to focus our management on resolving the mucosal edema of the sinuses. How will you do that? Yes, by either, let us see the choices, steroid irrigation and antihistaminic, revision surgery, macrolides for 4 months, biologicals. What do you think is the most appropriate answer? Yes, this was a very direct, very simple question. You just have to aim at resolving the edema of the maxillary sinus. What will you do? Yes, as I've already told you, always told you so many number of times that steroids play a very major role in the management of conditions of the nose. Now, if there is any allergy, we give steroids, yes. But even if there is no allergy, even if it is a chronic sinusitis patient, the first management is what? It is always medical management. And in the medical management for chronic sinusitis also, we give antibiotics. But along with that, steroid nasal spray is also given. Why? Because the cornerstone of management of any chronic sinusitis or any infections of the nose is to maintain the patency of the osteometal complex area so that the ventilation and drainage of the sinuses is restored, right? In early cases when the edema is very less, infection is very less, we can just do it by steroid nasal sprays. Whereas later on, if this medical management has not worked, then we restore the ventilation and drainage of the sinuses with the help of surgery, with surgery FES. Yes, so now in this patient, there is just mucosal edema, there is nothing else. The ostia is also patent. So the best management here will be, yes, tell me, steroid irrigation. What is steroid irrigation? Yes, it is same as topical nasal steroid that you are giving to the patient, not in the form of spray, but in the form of irrigation, like how we do alkaline nasal douching with the help of a bottle. Saline is filled and it is pushed, the saline is pushed into the nose. So here steroid is also mixed in that solution of saline, and it is irrigated, the nose is irrigated. So that is what is saline irrigation. And antihistaminic, probably antihistaminic has been given because this is just postnasal drip, probably this is the patient of allergy. So yes, so the most appropriate answer here is steroid irrigation and antihistaminic. Only if the medical management does not work, then we go for revision surgery. So coming to the next question, a male presents to the OPD with saddle nose deformity. He gives a past history of cough on and off fever and hemoptysis. Okay, so there is saddle nose, there is hemoptysis, cough, past history. On examination, there is septal perforation and granulations in the nose. Chest X-ray shows multiple cavitatory lesions. On histopathology, granuloma, multinucleate giant cells and necrosis is present. What would be the probable cause? Okay, so here we have a patient who has come to us. He has presented to us with what complaints? With saddle nose. Saddle nose, yes, means a lot of destruction has happened in this patient quite early. He has presented with saddle nose, right? And also he is presenting with what? With hemoptysis, which means there is extensive involvement of the nose, along with there is extensive involvement of the lungs, and yes, the X-ray also shows cavitatory lesion. So here let us see at the choices. We have Wegener's, syphilis, TB and sarcoidosis, and we have two main symptoms here, saddle and we have hemoptysis. So let us see in which condition it can be present. In Wegener's granulomatosis, can saddling of the nose be present quite early? Yes, we know Wegener's causes a lot of destruction. It causes perforation both in the cartilaginous as well as the bony part. Yes, so the destruction of the septum is widespread, cartilaginous as well as bony, and yes, in early stages also it can lead to a lot of destruction of the nose. So saddling, yes, can be present here. Hemoptysis in Wegener's, yes, cavitatory lesions, yes, they are present, so it can be present. In syphilis, can saddling be present? Does syphilis cause a lot of destruction of the nose? Does it involve the bony part? Does it involve the cartilaginous part? Yes, it can involve both. Saddling can be present in syphilis also. Hemoptysis as a presenting feature of syphilis? No. Lung involvement in syphilis is very unusual, and that too as a presenting feature. Hemoptysis, cavitatory lesions of the lungs? No, it will not be present. Tuberculosis, can there be saddling of the nose? Tuberculosis affects which part of the nose? Yes, I have told you that all the granulomatous conditions can cause perforation in the cartilaginous part. But there are two important things which can cause perforation in the bony part also. Which are those? Yes, one is the Wegener's and the other is syphilis. Now there is one lymphoma of the nose, the natural killer lymphoma or the Stewart's granuloma of the nose, and it will not cause saddling, it will cause gross destruction. There will be gross destruction of the nose. The whole of the nose would have been destroyed. It will not specifically cause only saddling of the nose, right? Saddling of the nose occurs when specifically the septum in the cartilaginous and bony part is destroyed. So in tuberculosis, it involves only the cartilaginous part, the bony part is not involved. Saddling as a presenting feature, we will never see. Quite late, that also rare, but saddling as a presenting feature, we will not see. And yes, cavitatory lesion, hemoptysis can be present, and TB of the nose also is not a very common condition. TB of the lungs, yes. Of the neck, of the lymph nodes, yes. But of the nose, TB is not very common. Sarcoidosis, can it lead to saddling? No, it cannot lead to saddling. It can lead to certain involvement of the nose. It can lead to lupus pernio, strawberry appearance of the external nose. It can lead to crusting, yes, but not saddling of the nose. And hemoptysis, can it lead to hemoptysis? Sarcoidosis, no, there are no cavitatory lesion. Hemoptysis is not present in sarcoidosis, so no. Yes, so what's the answer here? Yes, it is Wegener's. So the answer here is Wegener's. In fact, Wegener's, I think, is a repeated question of be it NEET or be it INI-CET. Yes, here the answer would have been more towards Wegener's if they would have given some kidney involvement also, renal involvement also. But still, if it is not there, the saddling and the lung involvement at presentation can help us to come to this diagnosis of Wegener's granulomatosis. Yes, one more thing I want to tell you is, whenever in the question there is a lot of crusting, there are perforation, there is granulations, we have to think of granulomatous conditions of the nose. Yes, along with, we can think of whenever there is a lot of crusting, atrophic rhinitis also. That is again a favorite question of your exam. So coming to the next question, involvement of jugular foramen leads to which of the following? Loss of taste from anterior 2/3, loss of sensation posterior 1/3, loss of sensation anterior 2/3, loss of taste and sensation anterior 2/3. Okay, so here we are dealing with the jugular foramen. In the jugular foramen, which nerves do we have? We have the 9th, we have the 10th and the 11th cranial nerve. And what is being asked is about the sensation and the taste of the tongue. So we know that 9th and 10th both supply the tongue. Which part of the tongue do they supply and what in the tongue do they supply? Again, the nerve supply of the tongue is a repeated question. So yes, in the anterior 2/3, the general sensation is by lingual, and the taste is by the chorda tympani. In the posterior 1/3, the most of the part of posterior 1/3, the base of tongue, the taste as well as sensation, most of the part anteriorly is anterior part of the base of tongue is what I'm talking about, is the 9th nerve, and the posterior most part of the base of tongue is taste as well as sensation is by the 10th nerve, that is the posterior most. Yes, and here just anterior to the sulcus terminalis we have papillae which are known as circumvallate papillae, and again the nerve supply of this also has been a question of your exams. Here it is the 9th nerve, the glossopharyngeal. So what do you think is the answer here? Yes, here everything is anterior 2/3, anterior 2/3, anterior 2/3. So the answer is very simple and very quick. The loss of sensation from the posterior 1/3, that is the answer. It is not only for general sensation, it is also for taste from the posterior 1/3. A patient with foreign body stuck at the laryngeal inlet has no cough reflex. Which nerve is affected in this patient? So now, as we have seen that almost every year in INI-CET, one question from the nerve supply of the larynx has been asked always, and previously when they were asking, what they were doing is they were combining the surgery with the presentation, like there is a base of skull injury, following that the patient has aspiration, or patient is not able to raise his pitch of voice, or maybe there is a thyroidectomy following which the patient presents with stridor. So these combination of surgery as well as presentation was given. Now here this has been a very, very simple direct question. A patient with foreign body stuck at the laryngeal inlet, no cough reflex. Yes, that reminds me that a question from foreign body, foreign body coin was given in your exam in the May session. So this is the nerve supply that is being asked of the laryngeal inlet. Yes, the laryngeal inlet, the sensory nerve supply is by, yes, the internal laryngeal nerve, the branch of superior laryngeal nerve. So that has probably got injured, because of which the sensation is not there, and that has not led to any cough reflex that will lead to aspiration. So yes, the answer is internal laryngeal nerve. Internal laryngeal nerve. So yes, those were the questions of the INI-CET November 2022. So I hope you were able to answer all of them. These topics are important, so do revise them.